You are welcome to my channel. Thanks for visiting. Remember to subscribe, listening to all my presentations and sharing them. Today is going to be all about abdominal migraine. Have you heard about abdominal migraine in the past? Someone had it around you, or you are treating someone with abdominal migraine, or you are thinking what could be happening to this child with abdominal pain and you're not getting another diagnosis as of now. Could it be abdominal migraine? No, this is not classic migraine. There's a separate presentation on classic migraine already published by me, and you have a link to that right here. So without much ado, let's go. Epidemiologically, abdominal migraine is uncommon. It will be very difficult to diagnose and most times wrongly diagnosed. Mostly found in 1 to 4% of children. I say mostly, but it's not limited to childhood because it could be found in adults. In children, when the diagnosis to be made is likely going to be between the ages 3 to 10 years. Some literature will put it as 3 to 10, some will put it as 7 to 10. Symptoms will be decreasing in frequency and severity as those children will grow older. Still on epidemiology, 90% of abdominal migraine will have positive family history of the same condition, that's abdominal migraine, or of classical migraine headache. So, hereditary, in nature, right? It is going to be found more in girls or females generally than boys or males. In fact, the migraine headache, if you listen to that presentation, I've stated there that the ratio of females to males in migraine headache is 3 to 1, respectively. The risk factors or triggers are similar to those of the classical migraine. We'll go over them in a bit. It is usually outgrown, but 70% of sufferers will later develop migraine headache later in life or full abdominal pain in adulthood. Clinical features. Of course, needless to say that there will be abdominal pain from abdominal migraine as the name, right? That pain could be moderate and sometimes might be severe. And it's going to last for 1 to 72 hours. But in between attacks, that same child will remain healthy or well. And here is the scenario, particularly to those who will be writing medical exams. They can put the history as a child, and they will put the age between 3 and 10, that the child will complain of abdominal pain. And then after 1 hour, even without treatment, the same child will get up and start riding the bike or sleep and may even be snoring. So you then be wondering, abdominal pain, 1 hour after, start playing soccer. That is abdominal migraine. That is the way it might present. With nausea or vomiting, loss of appetite or pale skin, you may not find these 4 at the same time, but we will not make that diagnosis without 2 of these 4 being present. There will be 5 attacks, with each attack lasting 1 to 72 hours. But we should note this: there will be dull pain around the umbilicus or belly button. The same pain that will be moderate to severe. The intermittent attacks will be greeted with days or months of free symptoms. Now, the differential diagnosis of abdominal migraine. Remember, I stated earlier that it is difficult to diagnose and could be wrongly diagnosed. So, if it is not abdominal migraine, then what could it be? Okay, might be pyelonephritis, urinary tract infection, cystitis, irritable bowel syndrome, Crohn's disease, pelvic ulcer disease, gastroesophageal reflux disease, might be cholecystitis, particularly in older people, intestinal obstruction, trauma, functional dyspepsia, pelvic inflammatory disease, pregnancy related in older people, and might be in teenager also anyways, appendicitis, and child abuse. But you look for the clue, you will get or you may not get. There's a big question. The patient may ask, what is causing this in me? Or the parents will ask for the child, what is responsible for this? Well, mostly when it comes to abdominal migraine, we don't know. And in medicine, we have somewhere to hide and we don't know the cause. We call it idiopathic. But we can reliably say that it's going to be related to classic migraine. So we'll take history of migraine in that family. And then we'll look into genetic and environmental factors as being contributory. Then triggers, prevention, and treatment of abdominal migraine is similar to those of classical migraine. Now, the diagnosis. Mostly diagnosed clinically. And remember, I said earlier that one could misdiagnose this condition or wrongly diagnose it to be something else. So, how can we make correct and definitive diagnosis of abdominal migraine? Let's go. First of all, we will ask history to rule out gastrointestinal, renal, hepatic, vascular causes, including food poisoning. So once that is ruled out, we cannot embark on any test per se because there is no definitive diagnostic test to be done here. So our history will further include that there must be 5 attacks, and each of the attacks will be lasting between 1 to 72 hours. And the history of each attack will include that there is a dull pain around the umbilicus or belly button. Then the pain is either moderate or very severe. And also, the history will include 2 of these 4: nausea, vomiting, pale skin, and loss of appetite. Still on diagnosis, because we want to be exact, right? We'll have physical examination done. Still to help us rule out other possible differential diagnoses here, we can have some tests done, and we are not doing those tests to make definitive diagnosis of abdominal migraine. We're having those tests done to rule out other causes of abdominal pain. And depending on the age of the child, we might embark on some definitive investigations like human chorionic gonadotrophin. Here, I will not be deceiving myself to think that I'm dealing with an adolescent and I'll skip this. You might do this and might help, depending on the level of suspicion, but then for you to be 100% sure the pain is not related to anything pregnancy, just get that done. Microscopic culture and sensitivity, you've been talking about TI and so on, get that done. Ryan, MCS, ultrasound if you're thinking of anything related, and of course you can even go ahead as for CT, depending on the degree of suspicion of other possible differential diagnoses. Now the treatment. We'll start with cognitive behavioral therapy. and keep a diary of the triggers. And once the triggers are known, avoid them like plague. Then, we advise that the child should have enough sleep, and of course, regular meals. Regular meals with generous fluid, particularly individuals who would have vomited lots. Avoid caffeine. It's not even advisable that children should be having coffee in the first place. Still on treatment, all medications for the treatment of classical migraine will be helpful here. But we are not going to go for all triptans in children. In children, we'll limit ourselves to sumatriptan and zometriptan. And of course, that child must be greater than 6 years and above. The treatment is individualized and is going to be based on the presentation. Now, risk factors and triggers. Let me leave a general note here. If you have listened to my full presentation on severity and migraine, I have explained there that you may not waste your time bombarding me with a lot of questions when it comes to triggers, because I'm going to say a lot right here. And the reason is that nothing is fixed as per the triggers. How do I mean? Triggers in one person may not be the trigger in another. No, it might be triggers in A, may not be triggers in B. Triggers in B may not be triggers in A. Other triggers may have to be present before some other triggers like food-related ones will actually have any effect. Okay? It is almost individualized when it comes to triggers. Okay? And the list here are just the common ones. In fact, it's not all the possible triggers that are right here, because I'm going to go through a lot. But that doesn't mean that is all we have. These are just the common ones. And common, not that everybody with migraine will definitely have them. No. Some will have some will not have some. Okay? It is fair to say that you can't avoid all the triggers listed. You can't. No. The only good advice here is study your own trigger or triggers by keeping the diary, and then avoid the triggers like plague. Now, let's go. The risk factors, hereditary. Majority of people with migraine will have positive family history. You need to find out from the parents about the history in the family. And this time around, when it comes to abdominal migraine, it is the duty of the physician who will help in finding out from the parents if this is running in the family. We should know this is going to be more in females than males. Environmental factors. We have to watch out for triggers, and when we pick them, we avoid them like plague. The environmental factors that could be associated will include stress, pregnancy, insomnia or sleep changes like shift work. That would be child abuse to have a child of 10 years having, work at all, let alone shift work. But I've said earlier, abdominal migraine is not limited to childhood alone. It could be in adults. Depression increased with weather changes, like in North America and Europe, where we can be down today with cold, winter, tomorrow come down with hot summer, and even in some part of Asia as well. Menstruation or menstrual changes will alter, the way that the migraine will be affecting the individual or not. You can conveniently say that this problem is both genetic and environmental. Okay, still on risk factors, certain medications or chemicals could act as triggers in classical migraine, but since classical migraine and abdominal migraine are closely related, so you can just pause and look through this. Now, caffeine Lifestyle and some other stuff. Too much caffeine is not good here, like too much coffee, wine, alcohol. It's by choice, but then you face some issues, right? Cigarette smoke, like secondhand smoke, cheese, too salty food, some processed foods, monosodium glutamate for seasoning, all could contribute to the attack. Certain places as triggers, particularly for classic migraine, can pause and go through. Certain other triggers are excitement, emotional changes, motion sickness, exhaustion, swallowing, excessive nitrates in processed meats, chocolates, and other processed foods. Caffeine. Seldom use might be helpful. Heavy consumption is a problem. Low to moderate can even help to reduce attack. But I'm not saying that in abdominal migraine because I don't expect children to even be taking coffee in the first place. This is more of classical migraine. Salty foods, ice cream, headache, egg cheese containing tyramine, foods having nitrates or preservation, just watch it. Monosodium glutamate is said by American Migraine Foundation to be a trigger in 10 to 15% of sufferers. Did you hear that? And of course, chocolates, also reported by the same group, that is American Migraine Foundation, is said to be affecting about 22% of the affected human beings. Of course, alcohol and artificial sweeteners like aspartame. Now, prevention. Prevention here is similar to those of migraine A to Z. Keep the diary of triggers. Avoid all known triggers like plague. All other medications for prevention of classical migraine will be helpful here. But don't add salt to the injury. If you keep giving non-steroidal anti-inflammatory drugs to a child, and if care is not taken, you're going to teach that child another problem, okay? Check the link for migraine A to Z. Complications. Abdominal migraine, since we've stated earlier that it's going to be found in children between 3 to 10 years, that will be school age, right? So less school days or frequent absenteeism, and that's bad. There will be difficulty in the diagnosis, and that difficulty has led to too many unnecessary tests being done, because the physician will probably be thinking of something more scary, sort of, right? And then a lot of time will be wasted, money will be wasted, besides the stress on the affected child. Wrong diagnosis is even worse. Wrong diagnosis with the wrong medications, and then the child is faced with side effects of those medications. In conclusion, information, they say, bring transformation. So you've known now that there is an entity known separately, and it's called abdominal migraine, common in children, but not limited to childhood. It could be found in adults. And you've known now that it could be wrongly or completely misdiagnosed. But thorough history with what I've listed under the diagnosis, you can pause and go back. You can make appropriate diagnosis and correct intervention. So help yourself. Help someone around you. Someone that would have been diagnosed with maybe something else entirely as the cause of the abdominal pain. Today, you might have a rethink. Are you going to go back to a physician, or as a physician, are you going to review that case again? Oh, well, that may be a possibility. So let's keep having human race. With that, I'm saying thank you for listening to this very presentation. Remember to subscribe if you haven't. Please share this presentation on your platform with everyone. Thanks for listening. I appreciate it.